Good afternoon, everyone. My name is Jane Walker, and I'm the Executive Director of the Family-Run Executive Director Leadership Association, or FREDLA. I'd like to welcome you to the webinar this afternoon on family-run organizations becoming Medicaid providers. This webinar is presented by FREDLA as a partner in the National Technical Assistance Network for Children's Behavioral Health, funded by SAMHSA. We have a distinguished group of presenters today. Beth Stroll is the President of Management and Training Innovations. I think everybody knows Beth as she's a pioneer and visionary in the field of systems of care for children and co-authored the seminal piece, A System of Care for Severely Emotionally Disturbed Youth in 1986, which I believe kind of set this whole ball rolling for all of us. She's also published at least another 32 publications since then, and today we're going to be telling you about the 34th publication that we are very pleased that Beth has partnered with us on. In addition to Beth, we have Jane Kalau, who is the Executive Director of the Family Involvement Center in Arizona, and Ricky Harris, the Executive Director of Tennessee Voices for Children, both of whom will be sharing their experiences in becoming Medicaid providers. The impetus for today's webinar and the guide that you will be hearing about as we go through the webinar is that Medicaid is the most rapidly growing source of funding for peer support services across the country. All state behavioral health departments and Medicaid departments are looking at Medicaid as a source of funding to sustain and grow peer support. In 2014, there was a document published by the Center for Healthcare Strategies titled Considerations for Family-Run Organizations for Becoming Medicaid Providers of Parent Peer Support. In that document, it provided information for family organizations to weigh their options and understand the basics of what it involves becoming a Medicaid provider. It included an agency readiness tool and a list of the pros and cons for boards and executive directors and staff to consider when taking that step into the Medicaid arena. This guide that we're going to be talking about today, designed for family-run organizations, but also a resource to state Medicaid and behavioral health divisions, is a resource that's more of an implementation guide with concrete guidance for family-run organizations that have made the decision and are ready to begin becoming Medicaid providers. It is designed to provide information and tools to help family-run organizations prepare for Medicaid-financed parent-peer support. Documents available at the end of this webinar will be the one I just referred to, the 2014 document on considerations for family-run organizations, as well as the PowerPoint for today's webinar, and a bulletin put out by the Center for Medicare and Medicaid Services that talks about Medicaid financing for peer support. A couple of housekeeping items before we proceed. All lines are muted. As you can see from notations on the right-hand column, there is a chat box. We're asked that you write questions in the chat box. This webinar is being recorded and will be available. There will be a link to the recording along with the resources in the TA telegram that comes out every Monday from the TA network. If you don't get that TA telegram, you can email FREDLA. We'll be sure to send it to you. And as I mentioned, you can download the documents. Will be available at the end of the webinar during our question and answer period. And the document itself, the guide that Beth Stroll has been working on for almost 2 years now, will be available, we're hoping, tomorrow or at Monday at the latest. The objectives of our webinar today are to describe the guide and how to use it, and to provide an overview of the 9 steps that are outlined in the guide for family-run organizations to become Medicaid providers. It offers examples of strategies used by family-run organizations, and today we're going to focus on 3 key steps in that process. The ones that are probably the biggest challenges for family-run organizations as they become Medicaid providers, and that is financing, administrative infrastructure, and staffing. I mentioned that we have Jane Callow and Ricky Harris with us, and since they're experienced in this area, they're going to be sharing their experiences and lessons learned from their respective states. We're going to be pausing as we go through each of the 3 areas, financing, administrative, and infrastructure. We'll pause and give you an opportunity to ask questions, put them in the chat box at the end of each of those segments, and then at the end, hopefully we'll have time for any additional questions you may have. With that, I'm going to turn it over to Beth Stroll.
Well, thank you for your kind words, Jane. Much appreciated. You make it sound like I've been very busy over the past few years, and I'm delighted to have been involved in this resource and creating this guide and working with Fredla on this. And as Jane said, this guide is designed to be a step-by-step resource that's really how-to practical information about what you need to think about and exactly what you need to do as you both prepare for and then become a provider of Medicaid finance parent peer support. And we've structured it so that you can use it in its entirety. You can use the entire thing. You can read it. Or you can just refer to various sections and the resources that are related to those sections when they become relevant to your work and when you need them in the process that you're following, in the journey that you're following to become a Medicaid provider. The guide defines parent peer support, drawing on definitions that the Federation of Families has done and others, and it outlines 9 steps to becoming a Medicaid provider. One of the things that I want to make sure people understand is that these steps are not linear. They overlap. They can be completed at the same time. So while we presented as steps 1 through 9, many of these you'll be thinking about concurrently, and you'll be working on each of them as you go along. In the guide, for each step, what we do is provide a description of what's involved in that particular step, and then we list some very specific tasks that you'll need to complete within each. And again, we tried to be as concrete as possible so that you can have some very in-depth, very hands-on, very practical information about exactly what it is you need to do. And then, as Jane mentioned, we have examples about how each of those tasks have been approached by the Family Involvement Center and Tennessee Voices for Children. And also in the guide, it shares something about the challenges that they've faced and the lessons they've learned along the way that might inform your work and help you to be aware of some of the pitfalls, think about them ahead of time, and maybe develop strategies to avoid some of them. So it provides you with information about how to undertake these, but also information about how to think about challenges inevitably that you'll face and how you might handle those challenges. And then a big part of the document is an appendix that includes quite a few resources. And those resources are taken from FIC and TVC, and they, again, are very practical kinds of resources. They may be guides for doing the staff documentation and paperwork. They may be outlines of the training programs that are used by those two entities. They would be descriptions of the management information systems or electronic health records that are used, contracts that they may have. So there are some very practical resources in the appendix of this document, and again, they're not necessarily ones that you all may need, but you can refer to those that are relevant to your work as you move through this process. In terms of the definition of parent peer support, you all know that it's become an integral part of the service array in the system of care concept, and that these services are increasingly available. States and communities are prioritizing them much more than they have in the past, particularly youth peer support. I think we have had more experience and more availability now of parent peer support, but youth peer support is a little bit behind, and there's an effort now to try to increase capacity and availability of youth peer support also. One of the major milestones is that peer support is included in the bulletin that was jointly created by the Medicaid agency, the Centers for Medicare and Medicaid Services, CMS, and SAMHSA, on home and community-based services that could be covered under Medicaid, that defines them and also shows what are the Medicaid authorities that could be used to cover those services. That joint bulletin is one of the documents that will be available for you to download, and it also includes a definition of peer support and shows how it's been used in some states and communities, particularly those that had, you may be familiar with the PRTF demonstrations, the psychiatric residential treatment facilities demonstration that was used to show how home and community-based alternatives can be used instead of residential treatment. And peer support was one of the services that was considered to be essential in making that possible, and there was a recommendation that Medicaid could be a vehicle used to cover it. And so now peer support is a part of many states' Medicaid plans and some of their Medicaid waivers. They're either covered by state plan amendments or by various Medicaid waivers. And in some states, though, we've only seen this for adult consumers. And currently, we're seeing the addition of parent and youth peer support in state Medicaid plans much more extensively. And another milestone for us is that in the new FOA, Funding Opportunity Announcement for SAMHSA's System of Care Expansion Grants, peer support is emphasized. And the grantees are encouraged, not just encouraged to, but are required to include peer support in the array of services and supports that they're developing as part of their System of Care Expansion initiatives. And peer support is defined not as a clinical service, but as a peer-to-peer support service, and the providers are parents or caregivers with lived experience. They have experience not just raising a child with behavioral health needs, but also with navigating child-serving systems themselves. So they know the frustrations, they know what it takes, they know what some of the issues are around having multiple case managers and multiple agencies to interact with. And so their role is to provide support to other parents or primary caregivers that is based on their common background and not on their status as experts. They don't purport to have all of the answers, but there is this shared background and this shared experience, and peer support is based on that. You know that there are different titles used for peer support: family partners, parent partners, family advocates, mentors, and many others. In our guide, we refer to it as parent peer support, and we refer to the providers of peer support as PSPs, parent and peer support providers, parent peer support providers. Across all of these definitions, there are a lot of functions that are common. All of them really focus on empowerment of parents and caregivers so that they can advocate for their own children and for their families and help them to get their own needs met. And the common functions are providing information and advocacy, helping them to navigate through the various child-serving systems, helping to connect them with natural supports that they might need, to make informed decisions, and also to partner more effectively with professionals. So these family professional partnerships can occur more effectively, and we can create teams to work on behalf of children and families. And there are also different kinds of organizational structures that can be used to provide parent-peer support. It could be a family-run organization or a government agency, a managed care organization, even a private provider agency, and in some places there's a blended model. We know that many of you as FROs have told us that that really is the most advantageous structure for ensuring fidelity to the model of parent-peer support and integrity to that role. But there is a lot of variation across states and communities across the nation, and there was a need for national standards, and so a National Certification Commission was formed, and a National Certification Program started in 2012, and that's being used quite extensively across the country now, in addition to some state-specific certification programs. But the National Certification Program is being recognized very broadly as one that is important for ensuring those core competencies and standards for parent-peer support providers, PSPs. And so here are the steps that we outline and discuss in detail in the guide. The first step is laying the groundwork, and basically this means taking a look at what the impact might be on the organization. Is it going to change your mission, your culture, your advocacy role? Important thing to think about at the outset of this. What is going to be the impact? Will the organization be perceived differently? Will it shift its functions in an entirely different direction, or can you maintain an advocacy stance as well as your role as a service provider? And also building relationships with key agencies in the state, and that's Medicaid, behavioral health, your managed care organizations, your behavioral health managed care organizations, other child-serving agencies. It's those relationships that are key to getting started off on the right foot. And step two is knowing the Medicaid program in your state. Well, how is it structured? How is peer support covered? Is it under a waiver, a state plan amendment? How is the Medicaid program run? Are there managed care organizations? Is it run through a centralized state agency? All of those things are important to find out how you, as a family-run organization, fit into this structure and what your contract might be like, who you contract with, who you would have to report to, who would be responsible for monitoring and auditing you, how you will be paid, et cetera. So knowing the state Medicaid program is a key step in this process. Step three is determining what the service delivery approach would be. And that is finding out what is your state's definition of parent-peer support. Does it match what your definition would be, or does there have to be either some negotiation, which may or may not be possible, or how do you have to adjust your own definition to be able to qualify with the state's definition in their Medicaid program? And what is the practice model that they require under Medicaid, and how does that compare with your practice model? And one of the aspects might be whether they require that PSPs have lived experience, or whether it's family-run organizations that have to provide the service, or can it be provided by other provider agencies? What's the length of stay? How long and how frequently can you work with families? All of those are part of the practice model, and it's important for you to know that. And collaborating with the state to modify these is part of that step. The fourth step is obtaining necessary credentials, and that's licensing, and there could be many kinds of credentials or licensing that an FRO needs to proceed. A facility license may be one type, but there may be others as well. Step 5, which is one of the ones we're going to focus on in more detail today, is around financing and rates. And here is a critical area for FROs, and it's important to understand what the state's contracting method is and how you would get paid. What are the rates that you would get paid for peer support? What are the billing codes you can use? And what are the time increments for billing, 15 minutes, 30 minutes, an episode a day? And what startup costs will you need in order to get going with parent peer support? And what kind of cash reserves do you need if there are lags in payment or other issues that you have to address before you're up and running? And while you're up and running as well. Step 6 is another one we're going to focus on today around administrative infrastructure, and this is one that's been somewhat challenging for many FROs. Deals with billing and financial management, staff documentation, technology, and common practices within Medicaid like audits and quality assurance, and then what kinds of insurance you require. Staff development, developing staff is step 7, and that's another one that we're going to focus on today. And it's you creating your staffing plan and hiring and retaining staff, and then preparing them with training, coaching, supervision, including how they're going to meet the requirements of certification. And the last 2 steps are initiating delivery of services under Medicaid, and that includes things that are critical, like a referral process. If you don't have a clear referral process and good relationships with provider agencies, you won't receive referrals for sufficient numbers of families for you to make this financially viable for you, and then processes for self-referral by parents as well. And new concepts for FROs are medical necessity criteria and prior authorization, and Medicaid does require those processes as well, and so FROs will need to understand and determine what those requirements and procedures are, and establish procedures within your own organization to comply with those. And the last step is around sustainability, and it looks at how are you going to plan for sustaining your parent peer support services, but beyond that, how are you going to implement a diversified plan for sustaining the family organization? And those are the 9 steps that we have included in this process, and we have studied them very extensively in FIC and TVC. And now we're getting to those 3 key areas where I'll just give a brief introduction and then turn it over to Jane Cowell and Ricky Harris to talk about their own experience in each of those areas. So the first step we're going to look at closely is financing and rates. And as I alluded to before, this deals with the contractual and financial aspects of providing parent peer support that's financed through Medicaid. It's a very difficult and complex process that can make or break this service for your organization. Some FROs have used outside consultants to help them with this, and the tasks include addressing contracting, payment, billing rates, billing codes, billing increments, limits on what can be billed, what cannot be billed, and then startup expenses. So let's start with contracting methods. First of all, this is determined by the state's Medicaid system, and an FRO can contract directly with the state Medicaid agency, or it may be a subcontract with provider agencies or managed care organizations or behavioral health managed care organizations. And all aspects of providing these services and providing peer support are shaped by your contracts. So it's critical for you to understand your contract, to have them reviewed by an attorney, by your board, or consultants, anybody that can help you really understand and dissect the language in the contract and know what it is that you're agreeing to. And this can be complicated when family-run organizations have more than one contract, multiple contracts with different MCOs or providers, and you need to plan to address that. So let me turn this over first to Ricky and then to Jane Cowell to talk about their contracting, how they have contracts with different MCOs, and what the processes need to be to respond to that. So why don't you start, Ricky?
Okay, thank you, Beth. So as it says here on the slide, TVC, we contract with 3 different managed care entities, and those are the 3 managed care entities identified by our larger Bureau of TennCare to administer the Medicaid dollars. And so we had to go through a couple of processes in multiple departments just to make sure we were clear in our general ledger and our accounting how we were identifying dollars from each different managed care company, and then also in our EHR, so in our system for tracking the documents and the progress that's made for each individual family. We need to be able to tell which managed care company was paying for their services. So we had multiple layers here of ways that we needed to identify the work that was getting done in the payer source. So just thinking about how you might, we use a coding system, so in our general ledger each different managed care company has a code. But just thinking through some of the areas in your organization that you might need to identify separate payer sources is a start. But I do want to reiterate the last 2 points that are on the slide that Beth put there. It is a little more complicated when the organization has the contract with multiple managed care entities. And then just planning from a business perspective, how you'll handle that is really critical, because once you start the work, there will be more times than you think that you'll need to go back and identify that particular payer source for a number of reasons. But one reason may be that you're tracking your funding. So for us, and we'll talk about this at a later slide, but for TVC, we have different rates with all 3 managed care companies, and so we need to track and make sure we're covering costs for those 3 different rates. And so I would just point that out as a really critical point here in the contracting method. And the other really quick thing I'll say, and then I'll turn it over to Jane, is just one of the parts that you'll have, one of the requirements rather that you'll have to likely go through, is a facilities application. And for us, looking back, we were really well positioned to go through our facilities application approval because we had state licensure, because we had the appropriate insurances and things that were built into our system for a very long time. Credit goes to people before I was involved. But if you're in a position to go through accreditation, I highly recommend considering that, because we are now looking at accreditation and we're seeing the value of how much, I don't know if the right word is easier, but less challenging it would have been to become an approved Medicaid provider had we had an accreditation. So I'll leave it there and turn it to you, Jane.
Thank you, Ricky. So much of what Ricky has covered is very similar for us here in Arizona. We started out as a family-run, not providing Medicaid services, but we were in a position where we were working with our state in changes in how our health waiver was used. So we did have the good fortune to be at more planning meetings about the direction and how the parent support role would be built in Arizona before we became a Medicaid provider. We were not a licensed facility or anything of that nature, so we did need to go through a big learning curve, but we were at a lot of tables learning what would be what we'd need to do. And I was preparing the organization too from a business side of the agency, how we would get into, bringing this valuable service to parents and caregivers in Arizona. So we've had 11 years of history with this, and I think some points that I'd like to cover too that make a difference. We are working in all three, providing services in all three managed care regions. There are three different managed care organizations, and two of them we are contracted directly with the managed care, and in the third one we are we've been under a subcontract with one of the large residential providers in Arizona to provide this service at a residential facility. So we are basically still working with three MCOs, just different contracting. I wanted to clarify too that some of the differences in the rate have to do with the geographics of the agencies, what type of a contract we have with the managed care organizations. We are an outpatient clinic nowadays, licensed and all that. We've gone through all that. But our contracts vary, like the one where we were doing work in a residential treatment facility, different arrangement altogether. In our other contracts, we are considered a direct support contractor, but we're a specialty. We probably have a different role than other direct contractors because we are direct support contractors because we're a family-run organization. What I wanted to explain too here is that we are in some areas we are getting our referrals through intake agencies where the families first come into services for their child. In some of those are not high needs families, they're more lower needs, so that's one type of referral. Second is we get our referrals from high needs case management organizations, and it makes a difference in where we're getting the referral in terms of our costs and how we look at analyzing the model of parent-to-parent support that we're providing. This we grew into this realization as we saw our system evolving, and it makes a difference in our business analysis of how we track costs and how we, the level of support that we're going to be able to give under those different referral sources.
Great. Jane, some of this is covered a little bit on some of these other topics, and I'd love for you to talk a little bit about payment methods. You have told me that it's a critical factor for financial viability, and so in addition to contracts, which you were just addressing. So you, in the past, I know, have gotten block payments where you get a 12th of the contract amount each month, and the advantages around cash flow. But fee-for-service is more common, and TVC has gotten that. So Jane, could you comment a little bit on the block funding, and then Ricky, a little bit on the fee-for-service, because I think that's very related to the contracting issues that you were raising previously. And then we want to also talk about rates and billing increments and limits. So we have a lot of ground to cover here.
Sure. I think we were fortunate to be able to start with block funding. If our starting contract was, say, $500,000 in one managed care contract, we would receive 1/12 of that every month. And at the same time, we would be, they would be tracking our what we called encounters, the billing that we submitted every month. And so there was an analysis going on between us. Are we living up to the contract standards? The work does not always stay level every month. Some months we would be over-encountering and billing more than what our 1/12 of our contract was. Other months we'd be under. But we were fiscally responsible to be able to meet that contract level by the end of the year. So it
ties our you know, our program in with our accounting. I want to make the point too, though, that this was not a special arrangement set up for the family runs. The majority of the outpatient services were being contracted for that way through other providers also. And we are just, in our one of our second contracts with the managed care organization, they set us up under both block funding and fee-for-service. And there were certain components of our parent support model that would be paid for, and referrals came in through the block funding contracting, and then others were fee-for-service, which opened it up to more providers to seek our services and go beyond the billing codes that were set up under our block funding. I think that's the key features that I want to share.
And Ricky, your contracts have been only fee-for-service, correct?
Yes, for our family support, it's only fee-for-service, and we currently do that in-house with a person who also administers some of the program function as a supervisor. But we will very quickly, if our volume moves beyond where we are now, we will very quickly need to think about how to dedicate a person to billing. And so just a tip for all you all thinking about Medicaid funding, when you start to figure out what your cost may be, put a billing person in there if you can, because you're going to need it if your volume increases at all within the first year.
That's great. Thank you. As far as rates go, we have found from both of your organizations, but also from others, that FROs don't typically have input into rate-setting processes, and they need to determine what the rates are in the state's Medicaid program, but that it's also valuable to document costs, and that could provide information that you could go to the Medicaid agency or the managed care organization, the MCO, and provide some justification for rate increases. Ricky, could you just comment about that first, and then Jane?
Sure. We certainly were fortunate to become a Medicaid provider at a time just after our MCOs and our Bureau of TennCare had announced that this particular service was going to be covered. So it was very new for our state. It was very new for our decision makers, and we have been at the table, as Jane mentioned earlier, we had been at the table for decades prior to this. And maybe fair enough to say for the last decade, we have been talking about this. And so when the time came to start setting rates, we were included in the discussion on how to get there and what the work looks like. In other words, we were never asked, right, what would be your ideal rate. However, we were asked, how often do you meet with families? What does that look like? How far do you have to travel, and how many times a month? And so those kind of things were considered. But as we went through that process for ourselves in preparing to propose a rate to the managed care company, we did just like many of you would do if you were to write a grant. We sat down and we looked at the cost of a family support provider staff, all the things that go with that, and we really determined not only today what does it cost, but for the future, like will we need a billing person in the future? How much might we pay that person? How do we factor that in? So really thought through the future and our longer term to make some proposals and pitch a rate to the managed care, which ultimately we were able to negotiate.
And that sounds like, and that would include some of the infrastructure that you need to make this work.
Absolutely, all the way down to training, EHRs, any kind of built-ins for billing in that system, et cetera.
Okay. Jane, can you comment on the rates?
Yeah. With our rates, yes, they are set at the Medicaid level, and the MCO has the ability to adjust those rates where if there's evidence that there's reasons that you'd need a higher cost if, say, in the rural area. But there are rates on the different billing codes are broken down by home, community, and office. And there's growing recognition. I do think this has been a partnership. As we have demonstrated why it costs more for a parent support provider to do this or that, or we offer a wide array of training, behavioral health promotion classes, which are an essential part of the practice model here for parent support. We've been able to demonstrate through different surveys, meetings, the benefits of this kind of educational platform, but we are able to demonstrate our additional costs, child watch, things like that, which has been taken into consideration in terms of determining our rates, and there are rates for doing home or community work with the parents are higher than office space too. So there are different ways of looking at how you deliver your services and how you can fit within the rates that you're getting, but you do have the opportunity to provide feedback and sometimes be at the table in planning changes in how we look at the practice model. And I think that's something to keep in mind, but being part of the practice model, it's going to be an evolving thing is my tip, that you're going to start one way, but you really have to have the leadership of your organization, your program, and your financial people working with your contractors.
Right. So even though you put the state presents you with rates or the MCOs, it sounds like with careful attention and documentation from you, there's the potential to work with them to make those rates more in line with what your actual costs are.
Yeah, definitely. Yeah.
Yeah. And you did get some, if I recall correctly, some increases from the managed care organization, right?
Yes. And some of this is an assessment that goes on over the whole practice model for all services, for children's services, not just what the family runs are doing.
Peer support. So another aspect of this is the billing codes and the billing increments and the limits that might be set. And as we mentioned, it's the Medicaid agencies or managed care organizations that determine what's reimbursable, what codes are used, what time increments you can bill, whether there are limits. And usually you can bill for 15 minutes or 30 minutes, or sometimes it's for a day or for an episode. But in some cases, there's a maximum number of units that you can bill for in a day or a month. And there might be some limits, like face-to-face is billable, but not help provided through the telephone. And there could be multiple billing codes like there are in Arizona, and you'll hear a bit about that. And there are typically non-billable activities like training, supervision, time spent in documentation, travel costs. And there may be the assumption that their rates are sufficient to cover those, but often that's not the case. And the FROs have to think about that in advance and have some strategies for how they're going to cover those costs. Jane, could you talk a little bit briefly about the multiple codes that you have to use and some of those limitations around what is billable, what's not billable, and how staff figure out what codes to use? If you can give us a brief sense of what that looks like.
Yes. Codes like self-help or peer support, we can do those in group or face-to-face. The group rates are, of course, much lower because it's establishing that you're going to have maybe at least 4 or 5 people in your group, and we know the likelihood of parents being able to get to these groups is not always as good as we'd like it. So we have to figure we need a detailed, oriented person looking at the operations all the time and how we plan and how we teach our parent partners in their work with the family. How do they meet the family's needs, but how do they keep in mind whether they use this code or that code, in how they plan their work with the family and how they are thorough in their documentation and interpretation. We have an individual that is available and assigned to them to look at their progress or their billing productivity every month or week, and we go through a lot of training with the staff. And we've had one thing I want to mention is that our early days, we were not able to bill parent-to-parent support by phone, and we really worked with the managed care and the Access, our Medicaid agency, to find ways for at least some of the billing codes that were eligible, so that we could use telephonic support. And we have been able to do that we've been able to use the case management code for that. And we have a committee right now that's been with family members, parent support providers, and people from our Medicaid agency and our Department of Mental Health Services, looking at how that can be expanded, not driven basically by what we need, but what the families that we serve through these services are going to need. So this is promising. We think we're going to be able to use some of other codes that haven't been available to us at the current time. So.
And you'll hear in a few moments some of the guidance that FIC provides to the peer support providers as to what fits under which code, and helping them determine how to do that with some very clear guidance. And as you can see, TVC just has one code, but it's different for each of the managed care organizations. And the last thing that we want to cover under financing here, the financing and rates, is around startup costs. And I alluded to before that there may be a gap between the time that you gear up for services and first start providing services and then receiving the first payments. And the lag time for reimbursements could be 30 to 90 days. So startup costs are important. You have to develop your administrative infrastructure. You may need to get hardware and software in place, train staff, develop client referrals, and you need startup funds or cash reserves to get through it, and identify those funds and understand that there is a lag time, and figure out how you're going to weather that cycle and any delays that come up. And some FROs have used a line of credit to do that. So now we'd like to move to step 6, which is around an administrative infrastructure. And most FROs have in the past focused on services more than infrastructure. And as we also talked about before, infrastructure should be built into the rates, the costs of the kinds of functions that we've been discussing around billing and such, but also for training, supervision, and such. But often that's not the case. And without this infrastructure, it's hard for FROs to meet the requirements for billing and documentation. So the tasks are billing and financial management, staff documentation, and technology. And we're going to take each one of those and get some information from FIC and TVC as to how they deal with that. In terms of billing and financial management, you need staff with expertise in billing and claims management and accounting and compliance, and most FROs won't typically have that in advance. And so what some FROs have done is hire staff as in-house employees to do this, or outsource this function to contract with firms that have experience and expertise in it. And FROs need to make sure that they do have sufficient resources to handle these kinds of functions, and it was recommended that you involve somebody with expertise early on in the planning process to make sure that you are building this in. Jane, can you address how you handle this? You are more of an example of outsourcing, and TVC is an example of handling that internally. So let's hear briefly, Jane, how you've handled this, and then Ricky, how you have.
Okay. We started out, hiring an accomplished billing specialist, but in an evolving system of care and Medicaid development of increasing this capacity in our state with all types of providers to provide a wider array of services, there's always changes happening in billing and codes, and there's many documents coming out all the time, and it really requires someone who's not just in the business of processing, but we needed more expertise. So we were fortunate in Arizona. There'd been some lot of planning going on, and there were a couple agencies that went into becoming billing specialists, claims processors, and we found that that was the best route for us to go. That was one less thing I, as the executive director, had to manage, bringing in all the expertise and things into our own staff. And so we've had that for, I think it's 9 years already, outsourced it, and it provides us other so we have help with our audits, we have technical assistance on anything, if there's any changes. We also use that service to complement the training that we do inside about billing. And this group that we've been contracted with for 9 or 10 years, actually has a good feel of how our agency operates. They know the staffing capacity, their skills, things like that, and they review our progress notes. They look at everything that they have a view of what we're submitting. They meet with the management regularly, and when we're running into problems that may be outside of our control right now, and there's something we need to do to communicate with the managed care organizations or our Medicaid authority, we have that extra expertise. And I think that has been, and it has helped us keep up with other technological changes that we needed to make. We didn't have to rely on our own internal staff to be watching all of that.
Okay. And you found that to be a more economical approach for FIC?
Yes, I have. The cost is based on the number of claims that are adjudicated, and they do provide a lot of expertise, and it's all done online. Our staff is very mobile. They have the technology. They help us keep everything, all the pieces together, so that our claims and our that we are not losing time having to resubmit all the time. They review everything before it's submitted to our managed care organizations and the access.
Right. And briefly, Ricky, how are
Yes.
you handling the billing and financial management?
So we had previous experience among ourselves, and then when I came in 2.5 years ago, I had come from some managed care work, so or work in partnership rather with managed care. So we had some inside knowledge and had some previous experience with billing codes that were not family support. So we used our in-house staff to do that work, but we set a threshold at what point what volume it would need to meet before we dedicated a person's full-time job to processing claims. And so we're not there yet, but we're very close. Two things I jotted down. We also planned for a very well-executed shift from our grant contracts that were coming to an end, that we would then utilize managed care funding to sustain the work of the family support providers. So we set strategies and mixed some of our grant funding contracts and our allocations, and slowly made a shift with our staff into the managed care positions, or the positions billing managed care. So we carefully planned some time allocations with our financial managers, and we just made sure, and we continue to make sure, that our program managers who oversee the work of a PSP really work closely with our CFO.
Yeah. And one thing I want to point out is that FIC has been these organizations are at different stages, and we felt we could learn different things from an organization that's been involved as a Medicaid provider for many years and one that is newer to the process. So FIC, Jane, you've been involved for, is it 10 years, or am I getting that wrong?
15 as an organization.
15 years.
11, and 11
right,
in Medicaid.
And TVC for a couple of years, is that right?
Yeah, three and a half or so.
3.5 years. So at different stages of the process, and we felt that you all would have a lot to learn from organizations who are at different stages of this process and could share their experiences based on their level of experience and level of development, really. Another important area in administrative infrastructure is around staff documentation, and both Jane and Ricky have referred to this, that Medicaid typically requires very detailed documentation. That's often challenging, it's complex, it takes time, and usually service plans with goals are needed, progress notes, summaries like monthly summaries, documentation of medical necessity, encounter reports, when you saw a family, for how long, where this took place, and such. So that's a lot of documentation that needs to be in the records in order to comply with Medicaid requirements and managed care organization requirements. And if you're audited, those things have to be in your records, and you have to be able to provide that information to them. So the PSPs need a lot of training and coaching to feel comfortable with this. Many of them have not had previous experience, certainly with this level of documentation, and most providers have not. And incomplete information can have some very serious results in terms of claims not being paid or payments withheld. So this is really an important function. Ricky, why don't you start with this one and talk about how you manage staff documentation, and then Jane, why don't you follow with some of the strategies that you use?
Sure.
Okay. So this one, I'm not going to lie, was a challenge for us to make some shifts to really meet the Medicaid standard here, because we were well positioned in that we already had an EHR. We use Qualifax, or some call it CareLogic. And so we had a good structure, we had a good tool, but we were not training staff to use it in a way that would set us up really nicely to meet all the needs that we would need to meet for the Medicaid requirements. So we retrained staff. Particularly, I want to point out something that I felt very strongly about was learning collaborative, or some call it concurrent, documentation. So being organized and being planful about your time spent in documentation was a big part of it. Being organized in your travel, or in our staff's travel, was a huge part of it. All of that played into this critical bear that we know of documentation. And for us, we decided to go ahead and add some resources to our EHR. So we included what's called an impact tool, and for us that means we can go in and pull data, pull analytics, look at time spent, staff time spent in productivity in face-to-face visits versus documentation. But we can also look at client outcomes. So if they put in a CANS assessment or a caregiver strain questionnaire, or any of the tools that we use, we're able to pull that back out of their documentation in our EHR and make some decisions about how to coach and train them to get the best out of the system they can get, and also to be as best organized and planful as they can be.
Yeah, great. And we'll also address some of this when we get to technology, and you will see that technology is an important part of staff documentation, and what kind of hardware and software are available to staff to do that, and what kinds of supports you can offer them to help them do that correctly, and support them in this function. So two of those, as both Jane and Ricky mentioned, are MIS systems, management information, and electronic health records. And the organization has to determine at the outset, do you need new hardware, do you need new software, and what will help you to complete these functions effectively. And a lot of Medicaid agencies and MCOs are requiring electronic health records that facilitate both reporting and billing and auditing, and developing this kind of capacity does take an investment up front. The cost to purchase software and hardware, training staff, supporting staff, and staffing specifically for the technology. And we also have found that FROs can either purchase software that exists out there, or can adapt an existing system that would help them fulfill these kinds of functions. TVC, and you just mentioned already, Ricky, that you use this Qualifax system, and that you're currently working on an electronic billing system, correct?
That is correct, and that function would be added to our existing EHR. So we are, our training for that is around the corner, and we cannot wait to stop paper billing and start electronic billing.
Yeah, right. That ought to reduce the workload tremendously on your staff and your financial people. And FIC, Jane, FIC has had a system that has had quite a long time to be fine-tuned, and it's called FICnet. Jane, can you talk a little bit about FICnet, what that does, how providers access it, what it can track, and what kinds of reports it generates?
Okay, our FICnet is it's a unique one that we developed based on a web-based system that we had for which is database, and we use the same claims billing group which has a technology entity or component within their structure, and we are all of our billing, our progress notes go into that through that system. But I want to point out I think the thing that what we've realized too is how important the support plans are that our parent support providers are using, and how well we take the referral from the referring agency and engage the parent who will be the primary recipient of our services, and really engaging them to find out what the needs are that will help this parent to be able to help their child and to be able to achieve the goals of the service plan, that the overall treatment plan for this family. And we have done a lot in our electronic health record system to be able to build in the support plan and the codes and billing codes that are going to be utilized by this parent partner. And it has the technology really helps shape and make sure that our plans come in with different billing codes on them. We have to cross-reference, do we think after we've engaged the parent that this is an appropriate level of service for the family? We have to sometimes negotiate with the referring agency to change that. But the system itself helps monitor and give us reports between our reports that we can generate inside for the individual parent partner to be able to see how they're doing, the manager of the department, and reporting that we do between our agency and the different managed care organizations that we contract with or provider agencies. And it gives us productivity numbers, the electronic health record for each enrolled family gives us progress reporting towards the goals and objectives that are in that support plan. And I want to add too that the technology that we have, our workforce is primarily, the parent support providers are mobile based. They do not have to come into the office. Often they're able to do all their notes from wherever they are at. We also use it for coaching and mentoring. We do a lot of go-to-meeting or staffings that where we're seeing individuals not following, being able to keep up with maybe their documentation, or maybe we're not seeing progress on some of the objectives that are in the support plan. We're able to do all of that electronically, and we can sometimes target trends within our staff where we need to do more training based on the reports that we can get from our system.
And one of the things, Jane, could you address just really briefly, are the supports that you provide staff members to do this, in terms of things like cheat sheets and sentence starters and those kinds of things that really help staff to do this effectively?
Yes, we've done, it's people, the staff that are hired probably didn't have experience in the, Medicaid documentation, and it takes a long time to learn how to do the progress notes, and there are guidelines really around when you're doing peer support versus case management, the things that are going to be looked at in an audit, data validation. And so we have created an array of tools to help individuals, and some of these are very specific to the various contracts that we have and what the expectations are. We are moving to a performance-based contracting out here, and we are trying to stay ahead of the curve in how we teach our staff and train them, and how we can help through templates that they can pull down and really it's sort of a reference guide for them. If you're trying to achieve this goal, these are some of the things you're going to want to make sure that's in your progress notes. We also, we are monitored, or we get, I guess I would call it, coaching and consulting from the managed care organizations too, on what they are looking at in our contracts, and in terms of collaboration with the referring agencies, collaboration between case managers, child welfare, case management that are in our teams, and we are, working that into our templates and things that they are referencing back to, that I need to mention where this is going with the case manager from child welfare and how this fits the goals of the plan.
Right. Good. Thank you, Jane.
Mm-hmm. Sure.
I'd like to move into the next area, which is developing staff, and we're going to keep this one pretty brief because we want to leave enough time for your questions and to have a little bit of a dialogue with you. And also, again, reiterate that a lot of this information is in the guide and will be given to you in much greater depth, and that all of the presenters, Jane and Ricky, and Jane Walker and myself, will be available to respond to your questions subsequent to the webinar. So the last area we want to talk about is developing staff. And you all know that without quality and competent staff, these services won't be effective, and there are requirements that managed care organizations or Medicaid agencies require, and FROs can add additional qualifications like lived experience if that's not part of the Medicaid requirements. Level of education has been a bit challenging for FROs. Some requirements from Medicaid agencies or MCOs don't count lived experience or volunteer experience toward the requirement of a certain level of education to be able to be eligible to be hired. And so that's a problem, and there are a number of organizations and states that have been working on that. Certification, as I mentioned before, is required increasingly, and a number of FROs are looking to hire PSPs, primary support providers, who are eligible for certification and also who are ready for the role. They can be hired as employees, they can be hired as contract staff, and also a thing to keep in mind is that there has to be flexibility, that many of the parent support providers have challenges within their own families that they have to respond to if their own children experience a crisis. So there has to be flexibility in the role within the agency. And the three things that we look at here under developing staff are developing your staffing plan, dealing with certification requirements, and then training, coaching, and supervision. So the first one of those is the staffing plan. And again, why don't you start, Ricky, and talk a little bit about what you do, and Jane follow by also mentioning some of the things that you mentioned for the guide in terms of looking for people who are ready and how you consider who you might think is appropriate for the role. So, Ricky.
So we, aside from what you see on the screen, I want to just add a few things that aren't there, because I think those speak for themselves. We only hire certification eligible staff because in our state, certification through the state certification process here in Tennessee is required to build a managed care company for the services. So that's a piece that we're uniquely in a really great place to know and understand certification eligible and what that looks like, because TVC, in collaboration with our NAMI partner here, are responsible for the administering the course that a FSP or PSP rather would take to become certified. So we have a long history of providing the training for certification, and we know what a well-trained and certification-ready PSP looks like. So I think we have developed a good eye there for what we're looking for in staff. I think I want to go a step further and say a couple of things. One of the first steps in staff readiness for us was really helping the staff understand why we were going to become Medicaid providers, and then getting their buy-in. Because you mentioned something earlier in the webinar, Beth, that for us was a really critical component, and it was coming to terms with who are we, and that advocate versus provider conversation had to be our first step. So we had to really understand we are advocates who provide service. We are not providers who also advocate. So that was really critical, that we all came together as an agency and understood how important that was and what that meant and why we were becoming Medicaid providers.
Right.
Furthermore, just looking at getting staff ready, part of what we talked about early in the planning, caseload sizes are critical here. So what's feasible, what's doable, what's your landscape, what's your geographic stretch you have to cover, and how many cases does each staff need to have, and so preparing them for that piece of it. So we were always looking for people who could work in a pretty intense environment, but we also have a great history, and this is why I think, to reiterate the point, why I think family-run organizations are in such a great place to provide this service, is we all share our understanding of what it means to have lived experience, and that sometimes affects your work, your day-to-day work. And so our supervisors are able to supervise sometimes what we would consider vulnerable staff, and they've figured out how to do that in a supportive way. And so we had figured that out, but then we changed and we said we're going to now bill Medicaid, and the rules change a little bit because there's a face-to-face requirement, and no longer do phone calls count for us, or there's a caseload requirement when before that was maybe a little less of a point, a priority, things like that. So carefully communicating and preparing the staff and spending some time on buy-in, I think, would be what I would want to say here to all of you.
Great, great. And Jane, would you like to address your staffing approach?
Yes. We, as an organization, we had a role in creating our wraparound or child and family team model out here, practice model, with, the state and the managed care organizations. And we have really tried to make it a practice to hire parents who have themselves received child and family team wraparound approach, those who have already had a parent partner, and we have been pretty successful in that, but at times we find that there just aren't enough parents who are ready to move into this role, and we do we adhere to all the guidelines about certification, and we had a lot of input into developing training at both the state level and regional levels, and we work closely with the managed care organizations to maintain that. What I wanted to add, though, is that we have found it necessary to bring and have almost like a pool of interns getting ready to be able to do the field and community work. We do have the opportunity to do telephone support, which is open to the community, and we have a training plan that we bring in and hire individuals that we are going to we know will move into the parent support provider, but they will do a lot, maybe a year inside the organization, becoming familiar with the essence of what the family run is about, how they use their advocacy skills that they came to our organization with, but how they meld into being doing the Medicaid parent support provider role in the community. And a point too is that we've made it individuals that come to work for us, parents that come to work for us, they have become successful advocates for their children. Non-adversarial advocacy is what we look for. How did they influence their child's service planning, and how did they help their child achieve the skills that he or she needed? And so we make it possible for our parent support providers staff to be able to participate in ongoing system of care meetings. It's something that we feel helps them feel they're a part of beyond the service provision, that they are still staying abreast of topics in children's mental health that they can contribute to. And we've found that useful too, because those that find that kind of additional role in their job with the Family Involvement Center, we see them growing and wanting to move into training roles with our organization, or they are the ones that often determine that they want to move into a supervisor or coordinator role. And it's another way of in continuing to develop the workforce, the supervisors and managers we need in our organization.
Right. And I recall an expression you used when we talked way back, Jane, was that you were looking for PSPs who, not just to have been through the child and family team process and have a lived experience, but that they're ready to give back. Mm-hmm. And I think that I loved hearing that expression, because I think it sort of captures what you're looking for in an employee who has been through this, but is at a stage in their own journey that they feel ready to give back to other families.
Yeah, exactly, and it helping them keep the passion for the work and know that they're making a difference. Yeah.
The last topic in this area around staff is training and certification. And I mentioned before that it may be required, that it could be the national program or state-specific processes that are required, and that certification requirements could include a minimum number of training hours. It could be a number of hours of supervision or practice, or a test with some kind of minimum score. Sometimes it's certification prior to being hired, but I think more often, and you all can correct me on this, it's that PSPs are given a specific period of time during which they have to pass the requirements for certification. And the certification processes can be online or face-to-face. Maybe they're observation and coaching. Maybe it's a combination of all of those. And the training and certification requirements in Arizona and in Tennessee are slightly different. Jane, why don't you start on this one, and then Ricky can talk a little bit about TVC.
Okay. Yeah, this is Jane. And our state has required peer support specialist certification for the peers in the adult system, but in the children's system, the parent certification took a little bit longer and to get established here, and we've been part of establishing that. There are parent support partners working at our agency and at other provider agencies that are not family run, and we've come together with the skills and competencies. And in addition to the certification, we also have a dedicated workforce development manager here, and we started, I think it was important that I recognize that we had to devote a lot of time to what is the training, what does this look like for the supervisors and the coaches. And when we started our certification platform inside for workforce, we started with them, and we took them through the process of being certified themselves. And we did this and as a group event, and with different skill levels that they had to demonstrate. And then we methodically went through each supervisor's staff, their work, their group of employees, and we did a lot of work where they supervisors and coordinators worked across their own staff to really take what we were learning as we trained them and took that back and redesigned some of our training. I also want to say that there's the core training that they get, but we are constantly using what we collect from our reporting and our data collection as what are the trends, what are the things that our staff are needing to know more about. And so we have continuous new training, unique needs type training that we are bringing to our staff and teaching them where the resources are and how to learn more so they can be more effective with the parents that they work with.
Okay, that's great. Ricky, your training certification?
Yes, so here in Tennessee, as I mentioned before, Tennessee Voices for Children developed the curriculum in collaboration with NAMI Tennessee for the competency course for family support training and certification. And the prerequisites for that course may be something you all are familiar with, parent to parent, or the NAMI basic curriculum. And those are both free courses here. And so once they have one of those two courses, they can go through our 3-day training and take the competency exam. And if they pass the exam, they can turn in their application for state certification, and really puts them on track then to go to work for an agency who is hiring PSCs.
Great, great. Now, question, are your competencies, the core competencies, a training program that you use for FIC, and your course outline and some of what's covered, are those available for other states and communities to use? Can they access those?
We aren't currently doing that. I think it's because it's been a work in progress, and we're going through a lot more working with our access agency, our Medicaid and Department of Mental Health Services and Managed Care. Arizona is going through a lot of changes, moving to integrated health, and we are actually, as an agency, working on what our recommendations are going to be for parent support providers working in medical facilities and that. So, but yeah, I do expect that we will have them available later.
Okay. Okay. I see Dennis Bach. You mentioned that you do the training and certification for Texas. Can you tell us briefly what you do, what your approach is? You have to unmute your line.
Hello, this is Dennis Bach. We developed a training certification program here in about 2011, I believe. And at the time, we looked around the country and didn't find any other models that we were interested in trying to borrow or steal. So we put together a stakeholder group of family partners in Texas and developed our own curriculum and training approach. So we've been doing that for about 4 years now. I think we've trained about 150 or so certified family partners. Almost all of them work for local mental health authorities. We have one that's based in a state hospital. One of the things part of the reason why I'm on the call today, and one of the things we're looking at, is the state is talking about doing an amendment to our state Medicaid plan to add a peer support provision, but they want to limit it to peer specialists and recovery coaches in the substance use world, and we're trying to see if we can convince them to add family partners into that as another type of peer support as well.
Great. Great, thank you. I just want to mention one more thing, and while I'm doing that, if you all would put your questions or comments in the chat box, Jane Walker and I will recognize you and respond and ask the other Jane and Ricky to respond to your questions. So if you have questions or comments, please enter them in the chat box now. I think we wanted to close with the idea that a balanced approach is one of the most important things that these two organizations and others that we have interviewed and spoken with find very critical, and that is how to keep a balanced approach between advocacy and a new role as a provider agency that's talking about providing Medicaid billable services, and that agencies are very concerned about separating these functions, maybe have obviously different funding sources for these functions, and having something of a firewall between them, so that the main or one of the main functions of a family organization, which is advocacy, system-level advocacy, is not lost as you move to also assume the role as a provider agency of Medicaid finance services. So there are some quotes here from Jane Cowell and from Jane Walker from Fredla and Ricky about this, about how Medicaid, being a Medicaid provider, has changed their role, but that it's important also to stay true to their model, to have a distinct role of advocacy as well as providing services. And I think the point made by Ricky of TVC is that by diversifying funding, this has enabled them to ultimately have a greater impact on more families. So the balanced approach, I think, is something that all of the organizations emphasize. And I see we have a couple of questions here. Lisa Fernberg talked about self-referrals. Can either you, Jane, or Ricky talk about parent self-referrals and how those are handled in the context of being Medicaid providers?
Okay, this is Jane, and we do have that in two of the managed care or contracts that we have. We work with the family to get, we determine with the family that's seeking our services where the needs are, and we put that together, and we then go to the managed care or the referring or the agency that they either are trying to get general services at or they are already enrolled in. And we are usually pretty successful in being able to get a referral for those self-referrals. But the pre-work that's being done is being paid by other funds. But it's still we do end up getting, the goal is to get them, if they're eligible for Medicaid services, to be able to have the funding come from that. And so there is some overlap sometimes.
Great, thanks, Jane. Another question is about defining the threshold at which you need a full-time billing person, and is there a certain minimum number of families that have to be served to warrant that, or is it a billing threshold? Can either of you respond to that?
Yeah, this is Ricky. I can say a little bit about that because we looked at it two ways. So when we were doing paper billing, and if we continued that, our number would have been 30 families being served. But once we shift to our electronic billing, we've decided that we would look at an amount of time spent in billing. So what we've asked the supervisor who's doing that to do is to track her time and to think about how much time we're willing for her to dedicate in her own role, which for us is we looked at 10% of her time. And then at what point she's over 10% that we need to start thinking about a part-time person. Really, luckily for us, she's very willing to experiment with us. So we kind of thought, well, if she's spending 25% of her time in documentation, then it's time to start thinking about a full-time person who can build this even further for us.
Okay. Kathleen, we are currently engaged in estimating startup costs in rate setting. Is there a national consensus about reasonable rates for service? Let me mention that there is a rate-setting webinar PowerPoint in the guide, in the resource section, that we'll give you a process to go through. And there also are some sample rates from Arizona. Whether there's national consensus, I'm not sure. Jane, either Jane, Jane W. or Jane K. or Ricky, is there any national data around this?
This is Jane W. And let me say there is another document that we can make available that is a matrix that also was done by the Center for Healthcare Strategies that kind of looked at what Medicaid was doing across the country. Now, how specific that was related to rates, I don't know. It's probably the most common question that we get, and we may need to start doing some surveys on that, because I know the rates have ranged I've heard from, $19 up to $100. So I will need to do more work on that. But do look into the matrix, and we can make that available also either through FREDLA or through the TA Telegram on Monday. Okay?
Yeah, I also think that in some cases the rates have been proprietary, and some of the organizations really have been unable to provide information about what their exact rates are from their MCOs and states. So I think that's a little bit of a barrier. But whatever information is available, we'll try to pull together for you.
And that's for 1 second. It's also really important to know what is included in the rate. What Medicaid, are they factoring in, time for supervision and the cost of the supervisor who's doing the supervision. All those kinds of things. You really have to tease it apart.
Okay. Carol, Cecil, you talked about your State Department worrying about whether an advocacy agency becoming a provider could have some type of an impact, and how do you allay their fears? I think either Ricky or Jane could talk about that.
Yeah, this is Ricky. I'll say something quick because Jane may have something too, because this is a huge one for us. But the advantage of a family-run organization and talking about this work for many of us is that we have experience doing the work far earlier than it was ever an option to bill Medicaid for the service. So being able to talk about, your longevity with the work, the experience that you have, the uniqueness of the relationship, that it's not a clinical per se relationship, and how you've managed that and the success you've had with it. For us, that was the strength in the conversation with managed care. And then furthermore, just being able to demonstrate if you have some outcomes and some work, how you're already set up to be successful in contracting the work, and then balancing the conversation with, we're advocates first who provide service, and we believe in the service so much that we've advocated that Medicaid put this into their full array of services and really rally around that concept.
And this is Jane. I would say that in our state, too, we started this work, we were at the table, and there was a recognition by our state mental health department and many of the providers that the parents who had received services and understood how the behavioral health system worked could be an ally to helping new parents coming into services with their child. They also recognized that parents brought a different perspective to service delivery, and that they could be a very valuable partner on service teams. And I think the word partner is what we as an advocacy agency too, we respect all of the clinical roles that are available, that are a part of our behavioral health system and Medicaid funded, and we really work to complement. And in the planning meetings, and I think we every few years we kind of regroup on things as a state or as a county and look at where we're going with our our Medicaid services and how the family runs and other types of specialty providers fit together in meeting the needs of children and families.
Can I add one more thing about that? This is Ricky,
Sure.
and I just want to say one more thing. For us, part of putting words into action with this and demonstrating to those who may have the concern about an advocacy organization being a provider, and to demonstrate that we are keeping advocacy at the forefront, is just to, when we engage in the work as a Medicaid provider, is to avoid and ignore the temptation to be competitive. So to really be the advocates in a way that we share with our partners the work, we share our expertise about the work. I mean, engaging in this project in and of itself, just making sure that our goal is to get the word out that peer support services work and they are extremely beneficial to families, period.
Yeah. That's great. Thank you. I think, Carol, your question related to your previous question about allaying fears about advocacy and provider roles, and Jane from FIC, I'm not sure if you mentioned this, but I know you mentioned in the document that you use different funding sources for each,
yeah,
and that you try to establish a clear demarcation between your system advocacy functions anyway and your functions as parent support and advocate for individual families. So I think that's an important thing to think about. I think we're running over. I don't want to take too much of your time. There are just one or two more questions that, if you'll bear with us, I think it would be easy to address. Lisa's is about details and documentations that have to be submitted with the claims, and are there federal standards, or does it fully differ by state?
This is Jane, and I'll just cover a few of them. We need to, in the progress notes in our documentation, show the location where it was, a length of time, who was present for this while this service was being delivered. We have to tie it to a goal or objective that's in the support plan. And we have to demonstrate how that service described is going to help the parent of the enrolled child, because of of course, all the claims billing is done on the child's enrollment. And and we also have to indicate what progress, a description of how this moved, or whether there was progress towards this goal.
Right.
And
I think my understanding is that this really varies by state and by MCO, and there might be some minimum federal guidelines, but I think it's really state and MCO specific, if I'm not incorrect there. Last question, and then I'm going to turn it over to Jane Walker to close this. The most progressive state in the political arena that helped in these efforts, that's a tough one. I certainly don't know. Does anybody have a sense of what the most progressive states have been around integrating parent-peer support into their Medicaid benefits?
This is Jane Walker. I would say it's probably more on the adult level than the child and family level. And we may be able to get some of our experts at the TA network to respond to that, like Sheila Pyries or something. But I think there has been much more going on the adult consumer level than the child level. But we'll find out.
Yes. And Kathleen from New Hampshire, it sounds like your state is one of the leaders in incorporating parent and now youth support in the Medicaid array. So maybe that's one place to start, right, Kathleen?
Yeah, good idea.
All right. So thank you all so much. I'm going to turn it over to Jane Walker to close close it up, and
Right.
we certainly appreciate all of your participation.
Well, I know everybody who's been on this call for the last hour and a half has just been enormously impressed with the breadth and depth of information shared here. I cannot thank our presenters, Dane Callow, Ricky Harris, and Beth Stroll enough. You can hear that this is not something that is either easy, simple, or fast. It is extremely complex, takes time, and I found in my own state when we stepped into this arena, it elevated our work. It elevated our work in the that it was considered more professional, and I think it elevated the staff in terms of looking at their own work in a more professional way. So I think there's challenges, but there's also benefits. And I cannot thank our presenters enough. You have their contact information. I am betting that they will get tons of emails. The documents that we referenced throughout the CMS SAMHSA information bulletin talking about the value of peer support as a Medicaid billable service that came out as a joint bulletin 2 years ago is there for your download. The document we mentioned early on, considerations for family-run organizations done by Center for Healthcare Strategies, is also on there, and this PowerPoint is on there. The recording will be available through a link that will be on the TA Telegram coming out on Monday. If you missed the link in this conversation of how to sign up for that, just email Fredla, and we can forward that link to you so you can sign up for the TA Telegram. And we can also see about getting the matrix I mentioned, the of Medicaid across the country and how they're handling peer support. And there is another document I wanted to mention in the context of Carol Cecil's comment about family organizations becoming providers. And that is another document that we were, again, fortunate to have Beth Stroll author. It was done from the National Association of State Mental Health
Program Directors.
Yeah, called The Role of Family-Run Organization in Systems of Care. It's an outstanding document, and we will also see if we can have a link to that in the TA Telegram on Monday as well. So again, thanks to our presenters, and thanks to all of you for joining us today. Have a great rest of the day. Thank you.
Thank you.
Bye-bye.